Apologies. So I said, thank you, Dr. Ranella, for walking us through the changes in the nomenclature. It was a long, but I think very rewarding process. And I'm going to share some of the issues around its practical implementation, what this means also in terms of public health and really growing the community of practice. So, you already mentioned how important this was to patients for various reasons, both making the disease more understandable and the recognition of multimorbidity, for medical experts so we can be more accurate and precise and have clear defining characteristics. I'll emphasize the importance of policymakers understanding that that MASLD is the most prevalent liver disease we've ever had, and policies need to be implemented really at all levels of society, both local, national, and at the global level. And finally, the societal perceptions that really need to change. There's still going to be stigma related to any liver disease, and especially liver diseases that are closely associated with being overweight or obese or alcohol. So, you mentioned some of the dissemination that was going on, Dr. Ranella. We're trying to reach the public, governments, and globally. You ended with a slide about the many organizations that have endorsed the new nomenclature, that it's being used in publications, the Healthy Livers, Healthy Lives sessions that have been held at professional societies around the world have also, to some extent, addressed the new nomenclature. And just a few days ago on World Liver Day, on the 19th of April, this was really put into focus. And here you have the World Liver Day logo, and this is an annual event that leading societies through Healthy Livers, Healthy Lives Coalition have endorsed to draw attention to all liver diseases. Obviously, those that are most prevalent are receiving rightly more attention. And when we think about MASLD and MASH, it's important to understand the risk factors. We often call it a lifestyle disease, but we also need to consider the commercial and social determinants of health, and recognize the common comorbidities, obesity, diabetes, and that means that in the liver field, we can't really go it alone. And the new name, metabolic dysfunction associated steatotic liver disease, really reflects that. It means we're engaging more with those in charge of obesity management, those in charge of diabetes, nutritionists, dietitians, endocrinologists, and others. I and many others feel that if we're really going to address MASH, the more virulent form of MASLD, we're going to need to seize on some of the opportunities this presents, and that includes nutrition-aligned drug rollout. So while the field has really been transformed since the 14th of March with a first MASH drug approval so far in the US by the FDA, but likely soon in the UK, the EU, Japan, and other countries to follow. There's a lot we can do to prevent MASLD and MASH, and there's also a lot we can do as we roll out and prescribe this drug, and that includes addressing nutrition simultaneously. So how do we do that? We can give advice to the patients, we can make recommendations, but we can also pull on other tools. We can have social prescribing, which will link individuals with suitable non-medical resources to enhance their well-being, and consider social nutrition, which is the what, the where, the how, and the why individuals eat, the likelihood of developing NCDs. And as you see here on the image, this includes, increased exercise, but also stress reduction and addressing mental health, having a healthy diet. But again, in social nutrition, we move into commercial determinants of health, socioeconomic status, culture, community, family, social support networks. And then again, where I stress the importance of engaging with policymakers, we need health promoting policies that are going to work to reduce health disparities, raise civil and society awareness. So I think this is a really important time for liver specialists, for hepatologists and gastroenterologists who will be the first to be prescribing the new MASH drug, that we can be thinking, how do we engage even more on nutrition, and how can we roll out nutritional interventions alongside the drugs that are being prescribed. So it's not just medical treatment, but it's also how do we engage peers, families, and others. Excuse me. So that means, as I mentioned earlier, as we grow the community of practice naturally to endocrinology and obesity medicine, we can also think about what's going to be the role of primary care professionals who are often addressing things that need to be addressed in order to address steatotic liver disease, like physical exercise, diet, and nutrition. How do we engage with cardiology, since this is the upstream activities that will hopefully prevent cardiovascular disease? And all that means we're starting to move from an era of disease-centered care more towards one that will be people-centered, where we're focusing on comorbidities. Remember, this is metabolic dysfunction-associated steatotic liver disease, and focusing on the health-related quality of life of the patients and of at-risk individuals. Optimal care models will need to be revised. So this was put forward by Dr. Ranella and colleagues for what will be the role of primary care providers and endocrinology, testing for fibrosis and using risk stratification, sending to specialists when needed, the role of weight management, nutrition and lifestyle interventions, importantly, addressing mental health through health psychologists, and then finally having the liver-directed therapies, identification of additional comorbidities, and so on and so forth. That means that we're going to need to start changing our models of care. This is from a few years ago, where a systematic review focused on the importance of non-invasive tests. Now we'll be able to prescribe the first MASH drug without a liver biopsy, but that means we need to be clear which NITs we're using in which order and what those cutoffs will be in order to treat the presumed MASH. Last year, the field came together just as we changed the nomenclature. We also set research priority agenda for steatotic liver disease. And in addition to treatment and care, we also need to be looking at the human and economic burden, community perspectives, education and awareness, and the leadership and policies. All of these can and should be researched. So it's not just a focus on treatment and care and how health systems are organized, but we're also researching what kind of education works. How do we best raise awareness? And that was followed by a study looking at the actions that need to be in place. And you see here these same 6 categories, models of care, engaging on human and economic burden, treatment and care, patient and community perspectives, but this focused more on the actions that need to be taken rather than just the research. We need research and action to really push this agenda forward, because all too often steatotic liver disease is not on the public health or the public health and development agenda at all. And so finally, as we build the community of practice, this is really how I see it. In addition to the healthcare providers on the upper left and the research community on the left that includes specialists, but also epidemiologists, global and public health researchers, we need to engage with the community you see on the bottom and the associated NGOs and CBOs, so both non-governmental organizations and community-based organizations, so that we can raise awareness among those groups who have an incredibly low level of awareness about what this disease is and why it's important to be addressed. And when we engage with industry, we're engaging already with pharmaceutical companies, with diagnostic companies, but we also need to be thinking about digital health and med tech more generally, because that's where the future lies, so that we can start prescribing medications along with digital health tools to help patients achieve the goals that are set for them. So with that, where do we go from here? We have a strong body of work from which to build. Dr. Ranella mentioned, the coining of non-alcoholic fatty liver disease back in 1980. We've known about this disease for over 40 years. Now's the time to really accelerate our efforts. Having a new prescribable drug should contribute to that. But the growing burden around the world, and mind you, the estimated prevalence is as much as 38% in adults globally, even higher in some countries. So that means we need to address not only social determinants, but also structural and commercial determinants of health, along with primary and secondary prevention and treatment and care. And that really means growing the community of practice. We cannot be preaching to the choir, so to say. We need to engage with policy makers, policy influencers, patients, and at-risk communities as stewards of change. So we can be thinking about this globally, bringing a common voice for more awareness and action on steatotic liver disease. That's one of the goals of the Healthy Livers, Healthy Lives Commission, but I think it's what we're all thinking about now as we enter a new era with a new nomenclature supported by so many organizations around the world, a healthy debate around what this means and who to engage with. So with that, I'll thank everyone who's contributed to all these studies and look forward to the question and answers with all of you.